All right. So welcome again to all of you. So I think it's 8 p.m. in Malaysia now. So it's 6 a.m. here in Rochester. So today we're going to talk about understanding diastolic dysfunction. I'm going to go very, very slowly. So the main reason we're going to do this is for you to understand and to use in your day-to-day practice. And of course, part of it is for you to pass the exam. So I have taken a few exams, the board exam in the US, and also the board exam in Malaysia. So I hope I can give you some tips as well. So we have what I call 10 parameters and 10 cases. So I will give you 10 cases, and I hope you can stay with me until the end of the 10 cases. And I also wanted you to remember these 10 parameters, okay? I know it's a lot, but try to remember these 10 parameters. So these 10 parameters is very important because when you want to assess diastolic dysfunction, these 10 parameters can help you decide whether the patient have diastolic dysfunction or not. And if the patient does have diastolic dysfunction, these 10 parameters can also help whether the LA pressure is elevated or not. So I will show you the 10 parameters at the beginning of the talk and at the end of the talk, okay? Now, the first is septal tissue velocity E prime that is more than 7 centimeter per second. Second is the lateral tissue Doppler E prime that is more than 10 centimeter per second. Third is average E over E prime that is more than 14. Fourth is maximum tricuspid regurgitation velocity more than 2.8 meter per second. Fifth is less atrial volume index more than 34 mils per meter squared. So this is the first 5 numbers that you really need to remember, okay? And this is another 5 numbers, which is the supportive numbers that you also need to remember. IVRT, which is isovolumetric relaxation time less than 70 millisecond. Deceleration time that is less than 150 millisecond. Pulmonary vein atrial reversal duration minus mitral valve A wave duration more than 30 millisecond. The presence of L wave and also changes with Valsalva maneuver. Okay. Now, all these 10 criteria will help you to determine diastolic dysfunction or to determine someone that have diastolic dysfunction, whether they have increase in LA pressure or not. Okay. Let's say you see an echocardiogram report, and how do you report diastolic dysfunction? Okay. And remember, when we're talking about diastolic dysfunction, we're talking about two things, which is impaired relaxation of the left ventricle. We're talking about left ventricle specifically. And does this impaired relaxation cause increase in left atrial pressure? Because that increase in left atrial pressure is important because it is the driver of the phenomenon of shortness of breath. Okay, impaired relaxation, increase in left atrial pressure. Now, this will then lead into grading. Okay, and how do we grade this kind of patient? Okay, so when we see echocardiogram, either the patient have normal diastolic function and therefore you don't need to do anything. Okay, so normal diastolic function meaning that their relaxation is normal and their left atrial pressure is normal. Or the patient have indeterminate diastolic function, meaning that doesn't matter what you do, you still do not know what is the diastologic status of the patient. Okay, hopefully using that 10 parameters, the indeterminate diastolic function will be very, very little, will be less than 1% of all the echocardiogram that you see. Okay, once you decide and looking at the echocardiogram, the patient have diastolic dysfunction, how to grade that? Okay, if you remember, there is 3 grades: grade 1, grade 2, and grade 3. Grade 1 is someone with impaired relaxation, but the LA pressure is normal. Okay, grade 2 is someone with a pseudo-normal tight filling of the left ventricle, and the LA pressure is elevated. Grade 3 is a restrictive filling, and LA pressure is elevated. So grade 2 and grade 3, both the LA pressure is elevated. Okay, so we have, if you look at the classification here, You have grade 1, normal LA pressure, impaired relaxation. Grade 2, pseudo-normal tight feeling, elevated LA pressure. Grade 3, restrictive type feeling, elevated LA pressure. Now, you can only grade the patient, okay, if the E and A, the E wave and A wave in your echocardiogram is a separate Doppler. If the E and A is fused, you cannot use E over A. Therefore, you cannot grade your diastolic dysfunction as you did with people in sinus rhythm. However, even in patients with atrial fibrillation, we can still tell their diastolic dysfunction. Rather than using grade, we can just use a sentence. For example, this patient with atrial fibrillation have diastolic dysfunction and normal filling pressure, one variety. Another variety is this patient have diastolic dysfunction, this patient with atrial fibrillation have diastolic dysfunction with elevated LA pressure. We cannot grade them because they don't have E and A separate. So either you have fused EA with increased left atrial pressure, or you have fused EA with normal left atrial pressure. Okay, and obviously people with atrial fibrillation can also have normal diastolic function, right? So now I have shown you 5 types. What other type there is? One of the most difficult part in terms of diastology is someone with significant mitral valve disease, significant mitral stenosis, mitral regurgitation, and prosthetic mitral valve. In this situation, most of the time, either you have indeterminate diastolic function, you cannot determine the diastolic function, or even if you can determine diastolic function and you can estimate the LA pressure, you can't really tell whether the LA pressure is elevated because of the left ventricle disease or because of the mitral valve disease. So that is the most complicated one. The other valve disease is simple. You can just use the normal algorithm, right? And the last one is the thing that I tell you, the 1% of patients that you can really cannot tell whether they have diastolic function or not. So I hope from now onwards, when you try to interpret an echocardiogram, you can see your patient is either one of these options that I show in the image here. And that is for atrial fibrillation there, fuse E over A, all right? I hope so far it is clear. This is the grading of diastolic function. Now let us understand the concept. Remember, diastolic dysfunction is about impaired relaxation. So the first question that we always have to ask ourselves is, what is the status of the left ventricle? Is the left ventricle diseased or the left ventricle is not diseased? Okay. Now, if the left ventricle is not diseased, you don't have diastolic dysfunction, as simple as that. Once you determine that your left ventricle is diseased, so you do have diastolic dysfunction, you have impaired relaxation, the question is, how bad is this left ventricular myocardial disease, and does it affect the left atrial pressure? So does the left atrial pressure increase or not, which can cause dyspnea? Okay. In order to understand diastolic dysfunction, and this is a detailed diastolic dysfunction talk, it is important to see hemodynamically what we're talking about. Okay, so look at the image here. This straight line here is the left ventricular pressure. So this is a isovolumetric contraction here. So this is this is ejection period. This is isovolumetric relaxation, and this is the relaxation period. The early part of relaxation is what we call rapid filling of the left ventricle, correspond of the E wave of the mitral inflow. Okay, early filling of left ventricle is the E wave of mitral inflow. The late filling of the left ventricle correspond with atrial contraction or the A wave of mitral inflow. Okay, now this patient have normal relaxation and normal left atrial pressure. If you see the left ventricular pressure here, as it come down very rapidly. It come down very rapidly, so that this isovolumetric relaxation is between 150 to 200, between 150, the isovolumetric relaxation is between 70 and 100 millisecond. Okay, the IVRT is between 70 and 100 milliseconds. Now, if you look at the LA, left ventricular diastolic pressure here, this is normal. And correspondingly, the left atrial pressure is also normal. So this patient have normal diastolic function and normal LA pressure. So that's number one. Let's look what happens when you have impaired relaxation. So as you have impaired relaxation, your left ventricle relaxes more slowly. Okay. So what you can see here is this downward movement of the left ventricular diastolic pressure, it becomes slower. What happens when it becomes slower? Now, as it becomes slower, this isovolumetric relaxation time go longer. So rather than between 70 to 100 milliseconds, it is more than 100 milliseconds. Deceleration time, rather than between 150 to 240 milliseconds, it is more than 240 milliseconds. Okay. Correspondingly, as the left ventricular pressure go down slower, the E wave actually go down. So the mitral flow E wave will go down. Okay. And correspondingly, the atrial contraction will go higher. So your E will be low and A will be high. So your E over A will normally be less than 0.8. This is grade 1 diastolic dysfunction. Grade 1 diastolic function, I repeat, slower relaxation during the isovolumetric relaxation time, increase in IVRT, increase in deceleration time, yet normal left ventricular pressure and normal left atrial pressure. So we talk about normal diastolic function, we talk about impaired relaxation. What about someone with grade 2 diastolic dysfunction and restrictive diastolic dysfunction? Both of them hemodynamically is about the same. So what happens is your left ventricle becomes stiff. Okay. Now, as it becomes stiffer, the rate of it coming down actually become faster. The reason it becomes faster, not because it's relaxed very good, it's simply because it becomes so stiff. When it becomes so stiff, it actually goes opposite way from the normal relaxations. So the IVRT, rather than prolong, it becomes shorter. So IVRT that is less than 70 milliseconds and deceleration time that is less than 150 milliseconds, that consider the patient have impaired, severely impaired diastolic function, either grade 2 or grade 3. Okay. Correspondingly, in this patient, the left ventricular diastolic pressure also go up. And as the left ventricular diastolic pressure go up, LA pressure have no choice but also increase to push the blood from the left atrium to the left ventricle. Therefore, LA pressure is elevated in grade 2 and grade 3, and patient feels shortness of breath. In grade 2 and grade 3, this E velocity will go high and the A velocity will be low, so that the E over A ratio will be more than 2. So this is either grade T or grade 2 diastolic dysfunction. All right. So let's recap. This is a line of someone with a normal diastolic function, normal LA pressure, normal IVRT, and normal deceleration time. Okay. As you get impaired relaxation, which is grade 1 diastolic dysfunction, this rate of slowing of the left ventricular pressure go down, it becomes slower, the IVRT go up more than 100 millisecond, and the deceleration time go up more than 240 millisecond, yet the LA pressure remains normal. If you go to grade 2 and grade 3 diastolic dysfunction, your LV pressure go up, therefore your left atrial pressure has also goes up. I hope you understand now. Grade 1, grade 2, and grade 3 diastolic dysfunction based on hemodynamics. Okay. Unfortunately, during the earlier phase of echocardiogram, we only have mitral inflow to tell us whether the patient have diastolic dysfunction or not. And this gives us certain problems, which I will talk about later. Okay. What is salient point of diastology? Number one, when we talk about diastolic dysfunction, we are talking about whether there is diseased myocardium causing impaired relaxation. And thus this impaired relaxation causes increase in left atrial pressure. Some of the diseased myocardium, it can be very easy to determine, okay? But for others, it is more complicated. What do I mean by obviously diseased myocardium? It is obviously diseased myocardium, we straight away know the patient have diastolic dysfunction, and what we only need to do then is to determine their left atrial pressure. So what do I mean by obviously diseased left ventricle is number one, someone with low ejection fraction. If the ejection fraction is less than 40%, you know the patient have diastolic dysfunction already. What about next? Someone with obvious regional wall motion abnormalities. Say someone with anteroseptal myocardial infarction and akinesia of the anterior wall of the left ventricle. Or someone with apical hypertrophic cardiomyopathy with apical aneurysm. This patient obviously have diastolic dysfunction. And the last one is someone with obvious abnormal left ventricular wall thickness. Okay, not left ventricular hypertrophy, I mean the simplified left ventricular wall thickness. Whenever I see the wall thickness, if it's more than 1.3 centimeter, I consider the patient to have left ventricular diastolic dysfunction. Now, because the normal thickness of the left ventricle for male is 0.6 to 1 centimeter, and for female is 0.7 to 1 centimeter. So you might ask me, why is 1.3 centimeter? Now, the reason we say 1.3 centimeter is because in patient with athlete's heart, it actually quite normal for them to have wall thickness up to 1.2 centimeter. It is absolutely rare for anyone to have wall thickness that is more than 1.3 centimeter unless you are an African American athlete. So remember these three parameters as someone that obviously have diastolic dysfunction. Okay. Now, because once you have all this, all right, what you need to do is just determine whether the patient have increased left atrial pressure or not. Now, the problem comes if someone come to your clinic with shortness of breath. When you look at the left ventricle looks normal. The ejection fraction is normal. No obvious regional wall motion abnormalities, and the wall thickness is less than 1.3 centimeter. Does this patient have diastolic dysfunction or not? In this situation, American Society of Echocardiography in 2016 published an algorithm to determine when the left ventricular look normal, whether the patient have diastolic dysfunction or not. So this is the algorithm that I show you, all right? And this algorithm consists of 4 parameters here. Okay, look at this, average E over E prime more than 14, septal E prime that is more than 7, that is less than 7 is abnormal, lateral E prime that is less than 10 is abnormal, TR velocity more than 2.8 is abnormal, and LA volume index more than 34 is abnormal. Now, if you remember, this is part of our 10 parameters that I asked you to remember. That's why I asked you to remember them. Okay. Now, if you look at these parameters, if more than 2 is positive, the patient do have diastolic dysfunction. You proceed and determine whether the LA pressure is elevated or not. If only 1 or there is none that is positive, the patient have normal diastolic function, you can stop that. What about if the patient have 2 positive and 2 negative? Okay, in this algorithm, they would say indeterminate. But what they mean is, even though it's indeterminate, please look at the supportive features. Okay, and that supportive features is the 5 other things that I mentioned to you just now. Okay, that other features are IVRT less than 70 milliseconds, that is really abnormal. Deceleration time less than 150 milliseconds. Pulmonary vein A reversal minus mitral valve A wave reversal more than 30 milliseconds. the presence of positive Valsalva maneuver or L wave. So if you have this criteria, rather than indeterminate, you can then say the patient have diastolic dysfunction. And you can then go to algorithm 2. Okay, I remind you again. What if everything looks normal? You have to use this algorithm first to determine whether patient have diastolic dysfunction or not. Okay, if don't have diastolic dysfunction, you stop. If have diastolic dysfunction, you go ahead to algorithm 2 to determine whether the LA pressure is elevated or not. Okay. Now, once we determine the patient have diastolic dysfunction, either from algorithm 1, okay, or the patient have diastolic dysfunction because they have diseased myocardium, like we said before, okay, reduced EF, abnormal wall thickness, and regional wall motion abnormalities, then we decide, is this myocardial, this diastolic dysfunction is bad enough to cause increase in left atrial pressure. Now, in this situation, mostly you only need to look at E over A ratio. Now, if E over A ratio is more than 2, you can stop there. You tell you that the patient have grade 3 diastolic dysfunction. Okay, that's your report. Now, if your E over A is less than 0.8, with an important caveat, don't forget this caveat, E must be less than 50 centimeter per second. E is less than 50 centimeter per second, you don't need to do anything else. Your patient have grade 1 diastolic dysfunction. So the grade 1 and grade 3 is really easy. Just look at E over A. What is your patient E over A? This is between 0.8 to 2, or your E over A is less than 0.8, but E is more than 50. So you have to look at these 3 parameters. And lo and behold, these 3 parameters is actually part of the 10 parameters that I mentioned to you previously. You see how important it is to remember the parameters. And if you use these parameters, if 2 or 3 positive, you have grade 2 diastolic dysfunction. If 2 or 3 negative, you have grade 1 diastolic dysfunction. So what you can see here, okay, if you have E over A at the middle range here, so even if you have a pseudo-normal feeling, okay, patient will have diastolic dysfunction, have E over A that looks pseudo-normal, their left atrial pressure can still be normal. It can still be grade 1 diastolic function based on this criteria here, okay. Now, in patient with grade 1 diastolic dysfunction, they complain to you of shortness of breath. It is important not just to brush out saying that, no, you have grade 1 diastolic dysfunction. Obviously, you don't tell like that to the patient. What you need to do is, if the patient is still symptomatic, you need to do what we call a diastolic stress test. You exercise the patient and you look at their E over E prime as they exercise. The E over E prime might start at 7, but when they exercise, it might be 20. The TRV max might be 1.9. Maybe when they exercise, it becomes 3.2. So this is what we call diastolic stress test. So stress test is not only for ischemia, it is not only for viability. Now we also do it for diastolic dysfunction. And we also do it now for valvular heart disease. Okay. I will show you 10 cases which we apply these characteristics. Okay. So I have mentioned about that before. Again, in this algorithm, again, if you cannot determine whether the LA pressure is elevated or not, again, you use your supplementary criteria. IVRT less than 70, deceleration time less than 150, primary vein atrial reversal duration minus mitral valve AVF duration more than 30 milliseconds, positive Valsalva maneuver, then the presence of L wave. I will show you what does all that means a bit later. Okay. Now, how does this all begins? Okay. How about the study of diastology begin? This is the earliest study on diastology published in Circulation in 1980 by someone named Yuzo Hirota. He said that myocardial relaxation is one of the earliest manifestation of mechanical dysfunction of the human left ventricle. And you know, when you look at the ischemic cascade, the diastolic dysfunction occurs first before systolic dysfunction. There is something that is called tau. Tau is myocardial index of relaxation. And what he determined is that as your myocardial of index of cardiac relaxation tau prolong, the worse is your myocardial relaxation. The normal value for tau is 33 plus minus 8 millisecond, and as it goes higher and higher and higher, the worse is your myocardial relaxation. And this is what they do in laboratory, not what they do in echo lab. So first, we go to laboratory first, and we learn about this called myocardial index of relaxation, tau. Okay? The longer the tau, the more impact the relaxation. Okay? With the advance of tissue Doppler, however, people noted that, okay, the E prime, which is the tissue velocity, how fast the septal and the lateral tissue move, it's inversely proportionate to tau. Okay, as the tau goes worsen, the E prime actually goes lower. Okay, so for the first time, with the advent of tissue echocardiography, we can actually tell whether the tau is prolonged or not by look at tissue E prime. Okay, so that is how this application come about. So at first, before tissue Doppler, what people have is only this left ventricular filling here. Okay, so this is supposed to be a normal pattern. This is supposed to be impaired relaxation. This is supposed to be pseudo-normal, and this is supposed to be restrictive. Okay, now we know that, okay, this patient with E over A that is normal, all right. Now, a patient can have this pattern but still have normal diastology. For example, patient that is elderly, the patient can have this pattern that still have increase in LA pressure. For example, patient when E over A is less than 0.8, but E is more than 50 centimeter per second. Okay. Now, as the left ventricular filling go from normal to pseudo-normal, you can see that the shape actually go back to the same. So this and this is impossible to differentiate. All right. And after that, you go to restrictive pattern. And again, in this restrictive pattern, if you are actually young and athletic, and your left ventricular actually suck blood very well, you can have this pattern even though you have a normal left atrial pressure. Okay, so this is a conundrum. What is the first conundrum? The first conundrum is the worse the relaxation, the E over A look the same as when it's normal. That is the first conundrum. The second conundrum is a lot of this E over A can be normal or can be abnormal. Like I tell you, this E over A here can have normal LA pressure, or it can have elevated LA pressure. Okay, this E over A here, it can be restrictive function, or it can be someone with athlete's heart. So what is the solution for all this? Now, the solution of all this, of course, in the advent of tissue Doppler. If you look at your E prime, okay, rather than coming back to the initial phase, the E prime actually go shorter and shorter and shorter and shorter as the diastolic function worsen. Okay, therefore, with the usage of a tissue Doppler, you can actually overcome the confusion. When you integrate the E and E prime, you can overcome the confusion given by looking at the blood Doppler alone. Okay, that is the advantage of tissue Doppler, and we can use that advantage. Okay, and we can also use again the parameters that I tell you, the IVRT, the deceleration time, and L wave to determine whether the LA pressure is elevated or not elevated. Okay, this is how tissue Doppler help you to solve the problem of diastology. I just wanted to show you a few echocardiogram example of what I'm talking about. All right. Now look at the top left of your diagram here. This is the pulmonary vein filling of your left atrium. Okay. When you pass the left atrium at the insertion of the pulmonary vein, you can see this filling here. The first thing here is the S wave. The second thing here is the D wave. This PVA is the atrial reversal during atrial contraction. Okay. In a normal people with a very good left ventricular suction, the S component of the pulmonary vein is lower than the D component of the pulmonary vein. This basically you see in young adult and also in athletes. Okay, in young adult and also in athletes. As you get older, or if you have impaired relaxation, what happens is that you can see that your S wave actually go higher than your D wave as you get older or you develop grade 1 diastolic dysfunction. As you develop higher diastolic dysfunction, your S wave actually go down again and your D wave go up, and on it goes when you have restrictive pattern. Okay. However, even though this pattern repeat itself, just like the mitral valve filling, you can see that the pulmonary vein reversal actually go longer from here to here to here, here, and here, here. So the reversal go longer and longer and longer. Now, if we were to measure this reversal here, how many milliseconds, okay, and you put a pulse wave at your mitral valve and measure the A wave duration of the mitral valve inflow, and you minus this millisecond that with mitral valve inflow length millisecond, if it's more than 30 milliseconds, you have increase in LV and diastolic pressure. That is one of the surrogate for increase in left ventricular and diastolic pressure. I repeat again. The worse your myocardial relaxation, the worse will be your reversal during atrial contraction. The longer it will be. As it get longer, when you minus this distance here, the time, minus the duration of the mitral valve A wave, if it's more than 30 milliseconds, you have increase in left ventricular and diastolic pressure. That's number one. Tips. The second tip is the L wave here. So when you put your pulse wave Doppler at mitral inflow, this middle part here that I show you, that is what we call a diastasis. During diastasis, there should not be any flow going between the left atrium to the left ventricle. If you see this flow here, and it's supposed to be more than 40 centimeter per second, then that is what we call L wave. And that is very specific for increase in left atrial pressure. And you not only see L wave in this mitral inflow, you also can see your L wave in your tissue Doppler. You can see that this is E prime, that is A prime, and that is the L wave here. So this is L wave. One favorite question in echocardiogram board in MMOD is this thing called a B bump. What is B bump? This is mitral valve opening. Okay, you can see that this is D point, E point, F point, A point, and C point. D point, E point, F, A, and C. However, you can see that from A to C here, you can see a bump, like a shoulder there. Okay, this is arrow there. That is also very specific for increase in left atrial pressure. We call that B bump. All right. So now I'm showing you three. One is pulmonary vein A reversal minus mitral valve A wave duration. If you still don't understand it, ask me during the question and answer session. Number two, I showed you B bump. And number three, I also showed you L wave, both in pulse Doppler and also in tissue Doppler. Okay. What about Valsalva maneuver? Now, Valsalva is also one of the specific finding of increase in left atrial pressure. So what happened is, you look at your patient E over A ratio. Okay, let's say the E over A ratio is more than 1, let's say 1.5. You want to see, is this normal, meaning that the LA pressure is normal, or is this pseudo-normal? So what happened is, you do Valsalva maneuver. What you want to see for positive result. Positive result meaning that the LA pressure is elevated. You want to see that the E over A ratio reduce more than 50%. Okay. Now, the top example is someone with what look like a restrictive filling pattern, you can see that E is very big, A is small. Okay, so you're wondering, oh, is this restrictive filling pattern? Okay, let's remember the 10 additional parameters. One of the parameters is Valsalva. Okay, let's do Valsalva. As you can see from here to here, it's when they do Valsalva maneuver, look at the ratio E over A to ratio E over A here, it doesn't change. Okay, so you know that this patient have normal diastolic function and normal LA pressure. This is just a young, fit athletes. Okay, what about the bottom one here? Okay, on first glance, the E over A is as high as E over A for the top here. However, as we do the Valsalva maneuver, you can see that the ratio of E over A here that is high actually come down to almost the same. So the E over A come down from 2.3 to 1. So there is more than 50% reduction. So this is positive. This patient have increase in LA pressure. This is negative. This patient have normal LA pressure. Okay, that is how we use Valsalva maneuver as our additional parameters. All right. This is again showing you the difference in terms of the pulse Doppler and the pulmonary vein Doppler. Okay, this is someone with a normal feeling. This someone is young and healthy. You can see the E is very high, the A is very low. The left ventricle is actually suck blood into the left ventricle, and correspondingly, the systolic component of the pulmonary vein is shorter than the diastolic component, and the pulmonary vein reversal is very short. All right. As you go into impact relaxation, or as you get older, you can see that your S wave go higher than your D wave. All right. And as the diastolic dysfunction become worse and worse, your E wave is higher than A, but your S wave now has come down, your D wave has gone up, and your atrial reversal has gone much, much longer. Right. So that is again normal, grade 1 and grade 2 diastolic dysfunction. So what happened is that Sharif Naguer published this paper in 1997 in JACC. All right, he showed that, okay, because the filling of the left ventricle, the E over A, is actually proportionate to the filling pressure over tau, and E prime is actually inversely proportionate to tau. So what happened is he noticed that if you divide E and E prime by echocardiogram, so this is E over E prime by echocardiogram, he noticed that if it's more than 15, the E over E prime, it's actually approximate the filling pressure that is abnormal. Okay, so E over E prime septal that is more than 15 in echo approximate abnormal filling pressure. So that is one of the genesis of E over E prime. This again just wanted to show you the pulmonary vein flow. Actually, I have said this over and over again, how you do it. All right, this atrial reversal get longer and longer as your diastolic function get worse and worse. All right, and it's actually quite sensitive and specific. As you can see here, the sensitivity is 85% and the specificity is 79%. And the good thing about these parameters is it is independent of ejection fraction and it's also age independent. Okay, this is a little bit of things that complicate our understanding of diastology. Remember that the older you are, the lower your E prime. So it is quite normal for your E prime to become low as you get older. Therefore, even though I tell you that the septal E prime less is 7 is abnormal, but if you see someone that is 20 years old, and let's say their septal E prime value is 9, you have to worry because that is abnormal for the patient. Okay, that is septal E prime. What about E over E prime? The E over E prime is actually very good. You can see, doesn't matter what your age is. Okay, E over E prime over 15 is way above. So that E over E prime is actually valid in all age group. Okay, so that is some caveat in terms of diastology. I just wanted to take a look at a question that I think in the chat group here. Now, I hope you understand so far the teaching. Okay, now we're going to go into case. Just let's recap what have we said before. Okay, let's just recap it. Okay, just recap that diastolic function is impact relaxation, and increase in the LA pressure. Recap the 10 parameters that I tell you need to know to determine whether the patient have diastolic dysfunction, and the 10 parameters, the same parameters that can help you in terms of determining whether the LA pressure is elevated or not. And remember, I tell you how we synthesize all that into our reporting of echocardiogram by using a combination of algorithm 1 when LV looks normal and algorithm 2 to determine whether the LA pressure is elevated or not. Okay, now we look at the case and then you will remember better. Let's look at our first case here. Okay, we have a 39 years old man who attended regular screening complaining of atypical chest discomfort. He's worried. He's having family history of heart disease. He does not have any shortness of breath. We do transthoracic echocardiogram. Okay. Now, the question that we wanted to answer is, does this patient have diastolic dysfunction or not? Now, always, to make your life easier, look at the left ventricle. Okay. See whether the left ventricle looks normal or not. All right. Now, in this patient, as you can see, the ejection fraction is 56%. There is no left ventricular hypertrophy. Okay, so the left ventricle, in all intents and purposes, actually looks functioning to be quite okay. So I wanted to ask you, does this patient have diastolic dysfunction or not? So you have to use which algorithm first. So in this situation, because left ventricle look normal, you actually have to use the algorithm 1 first. All right. Now, the left ventricle look normal. Let's look at the algorithm 1, whether the left ventricle is normal or not. Okay. Now, look at the left atrial volume index. In this situation, the left atrial volume index is 37 mils per meter squared. Is it normal or abnormal? Remember, 34 is normal, so this is abnormal. TRV max is 1.77, that is normal. Septal E prime is 13.6, that is normal. Lateral E prime is 17.5, that is also normal. Septal E over E prime is less than 14, that is also normal. Remember, this patient has a normal looking left ventricle. We need to use algorithm 1 first. Let's go to algorithm 1. This patient have normal looking left ventricle, not just normal left ejection fraction. We look at the 4 criteria here. None of the criteria is positive. So this patient have normal diastolic function. You do not need to go into the algorithm 2. Straight away, you know the patient have normal diastolic function and you know this patient have normal left atrial pressure. In your report, you can just say normal diastolic function. I hope you understand our case 1 of patient with normal diastolic function. Okay. Look at our second case. We have a 27 years old marathon runner come for athlete screening in IJN. We do a transthoracic echocardiogram for this patient. He is completely asymptomatic, right? Now look at the echocardiogram here. Now I want you to look at the left ventricle here and say in your heart, does the left ventricle looks normal or does the left ventricle looks abnormal? Are you going to straight away go to algorithm 2 or are you going to use algorithm 1 first? Okay, I give you some extra information. The patient have wall thickness that is 1.1 centimeter. Decide whether that is abnormal enough to straight away go to algorithm 2. The patient have left ventricular mass index that is 125 gram per meter squared. Normal is less than 115 for men and less than 95 for women. The relative wall thickness is 0.32. Okay, normal is less than 0.42. The patient have eccentric hypertrophy. Now the question is, does the patient have diastolic dysfunction or not? Look at the left ventricle. Does it fulfill the 3 criteria that I tell you? You can see that it doesn't. Therefore, you cannot go to algorithm 2. If you go to algorithm 2, you will go all right. Okay. Now let's look at the parameters and we decide. Looking at algorithm 1. Okay. So this is the parameters. Now we know that the septal E prime is 18 and lateral E prime is 15. Now that is normal. Okay. Look at E over A. E over A is 2.3. All right, so let's look at the parameters in entirety. LAVI is 37, abnormal. TR Vmax is 2.3, normal. Septal E prime and lateral E prime is normal. Average E over E prime is normal. On a first glance, this E over A that is more than 2, you said, this patient have restrictive diastolic function. Think again. This patient who is athletic, who's in front of you, who is asymptomatic, is it possible to be restrictive diastolic function? No. If you go to algorithm 2, you will make mistake. So you go to algorithm 1 first, right? Now, so let's look at the algorithm 1. Okay, if you look at algorithm 1, even though the left atrial volume index is abnormal, it is high, but that is only one criteria. So one criteria is abnormal, but 3 is normal. So if you follow the algorithm, the patient actually have normal diastolic function. You do not need to go into algorithm 2. Because if you go to algorithm 2, E over A is more than 2, you straight away will say the patient have restrictive diastolic function, which doesn't make sense. Okay, so how do we explain this patient? All right, so this patient have EA over 2 because this patient have supranormal diastolic function. The left ventricle actually suck the blood so fast from the left atrium such that the E over A is more than 2. Okay, it's just simply normal diastolic function. All right. If you look at the S over D ratio in the pulmonary vein, you can see that the S ratio is actually lower than D. This happened in patient that is young. So basically, this patient have athlete's heart. I give you some tips about athlete heart. Okay, the LV relaxation is so good that the blood is sucked into the LV from the LA, mimicking restrictive pattern. The dilated LA and the mildly elevated TR is normal in athletes. And most importantly, almost no athletes have heart that is bigger than 1.3 centimeter, unless the patient is an elite male black athletes. The problem with athletes is, okay, you have to remember to differentiate from hypertrophic cardiomyopathy. Athletes have chamber dilatation in almost all chamber. So LV is dilated, LA is dilated, RV is dilated, RA is dilated, IVC is dilated. Okay, IVC can also be dilated. Patient with hypertrophic cardiomyopathy, the cavity is small. Okay. What else can you do in athlete heart? You can actually do strain. You expect the strain to be normal. You expect the patient will exercise very good. One of the things that you can use is CPAT, cardiopulmonary exercise testing. All right. Usually athlete, their capacity will be more than 50 mils per kg per minute, or more than 120% of what expected for their age and gender. All right. What about ECG? Remember, in patient with athlete's heart, okay, they can have ECG that looks abnormal, but it's actually normal. However, athletes should not have key inversion that extend to lead 4 to 6. Okay, 1 to 3 is okay. 4 to 6 is a no-no. They can have the voltage criteria for left ventricular hypertrophy, but they cannot have the ST depression. Okay, and they cannot have LBBB or RBBB. You have to investigate that in athletes. Okay, so this is an example of someone with athlete heart with supranormal diastolic function where we use algorithm 1, 2. That is our second case. Let's look at our third case. Okay, it's important to be patient. Okay, we have a 67 years old man with history of hypertension and diabetes mellitus. Already there's a red flag there. Come with worsening shortness of breath, bilateral pedal edema, and ascites. Okay, another red flag. The NT-proBNP was 5,000 as abnormal. Okay, now, does this patient have diastolic dysfunction? Let's look at the parameters. The ejection fraction is normal. The thickness is only 1.2 centimeter. And there is no obvious regional wall motion abnormalities. Even though this patient is old, look at this patient left ventricle and tell me, are you going to go straight to algorithm 2? Are you going to use algorithm 1 first? Okay. Now, in this situation, again, as long as the left ventricle looks normal, always use the algorithm 1 first. Okay. So let's use the algorithm 1 for this patient. All right, so that is the patient numbers. You can see that the larvae is 43. You can shout at yourself, is it more than 34? Yes. Look at septal E prime, it is less than 7. Look at lateral E prime, it is less than 10. Look at average E over E prime, it is more than 14. Okay, so what happened? Out of 4 criteria, 3 criteria is positive. Okay, so you use algorithm 1 first. The LV looks normal. However, as you can see, 3 criteria is positive. So by looking at algorithm 1, you decide, this patient have diastolic dysfunction. Our question now is, what is the left atrial pressure? Is it elevated or not? Now we use the algorithm 2. Okay. Now we use the algorithm 2. The E over A is 1.74. So E over A is between 0.8 to 2. All right. So what do we need to do? We have to look at the 3 criteria here. And the 3 criteria is the same as the criteria here. And the patient actually fulfill all 3 of the criteria. So this patient actually have diastolic dysfunction, have increase in LA pressure. The E over A is 1.74. So this patient have grade 2 diastolic dysfunction. Okay, so this is our third case. And this, ladies and gentlemen, is always missed. This is a typical patient that come to you with heart failure and preserved ejection fraction. All right. It's a typical patient with heart failure and preserved ejection fraction. It's usually an elderly with multiple comorbidities coming in with shortness of breath, pedal edema, but preserved ejection fraction. The only differential diagnosis of HFpEF is the HFpEF secondary to cardiomyopathy like hypertrophic cardiomyopathy, amyloidosis or Anderson's fibrosis disease, or the other one is constrictive pericarditis, which is coincidentally the title of our next talk. In this patient, the LA pressure is elevated. Diuresis, controlling ischemia, and hypertension will help. So what you do is, if you give this patient furosemide, you can actually repeat the echo and you see the LA pressure come down. Okay. Don't confuse typical HFpEF. HFpEF is patient with multiple comorbidities with cardiomyopathies, like I told you before. And I wanted to give you one more tips. Okay. Whenever someone presented with heart failure and we are thinking of myocardial disease, you can look at what I call triplet tissue velocity, i.e. S prime, E prime, and A prime. If all the value is less than 5 centimeter per second, the myocardium is actually very sick, right? Let's look at our case number 4. Someone with newly diagnosed as apical hypertrophic cardiomyopathy. Red flag, apical HCM. Does the patient have myocardial disease or not? Okay, remember that the diagnosis of hypertrophic cardiomyopathy need a thickness that is more than 1.5 centimeter, unless you have first degree relative, in which the threshold is go below to 1.3 centimeter. Okay, come for a regular follow-up in cardiology clinic. Complaint of dyspnea on exertion. Okay, is this because of diastolic dysfunction? All right. Now let's look at the echocardiogram. This is not a moving echocardiogram. However, let me tell you that the apical thickness is more than 1.5 centimeter, right? When you do contrast, the patient have diastolic spade-shaped pattern. The apical thickness is 1.5 centimeter. Ejection fraction is preserved at 60%. Does this patient have diastolic dysfunction or not? Do you need to use algorithm 1 or not? No, right? This patient already have myocardial disease. It fulfill our third criteria, wall thickness that is more than 1.3 centimeter. Right? Now, furthermore, when we do strain, you can see that the apical is affected really, really badly. Normal value is negative 18 and more negative than that. This is really, really bad. So you know that the patient have myocardial disease. This is exactly opposite to someone with cardiac amyloidosis. So in this situation, we do not need to have headache. We straight away to go to algorithm 2. And remember, even in algorithm 2, the parameters is still the same. Let's look at the parameters here. The patient have E over A that is 1.29. E over A that is 1.29. All right. E over E prime is 9.3. LAVI is 31. As I told you, this patient have myocardial disease, Don't need to go to algorithm 1, go straight to algorithm 2. Go to algorithm 2, the patient is at the middle. E over A is 1.29. So we have to look at these three criteria. However, two of these criteria is negative. So even though the feeling looks pseudo-normal, the patient still have grade 1 diastolic dysfunction. So this is a patient with apical hypertrophic cardiomyopathy, have diastolic dysfunction but normal LA pressure, grade 1 diastolic dysfunction. Why shortness of breath then? Remember, in the stem, the shortness of breath is on exertion. So exercise the patient. When you exercise the patient, you can catch diastolic dysfunction that occur in exercise. All right. Let's go to our next case, guys. Okay. So, okay, let me give some explanation first. Okay. This patient already have myocardial disease, so patient already have diastolic dysfunction, which is further supported by the fact the apical longitudinal strain is greatly reduced. So we just need to straight away go to algorithm 2. Since the E over A is 1.29 and two criteria is negative, the patient actually have normal LA pressure. Grade 1 diastolic dysfunction, okay? We try to exercise the patient. Let's look at our fifth case. We have 20 years old with diagnosis of hypertrophic cardiomyopathy. Again, red flag there. Come to the emergency department with pre-syncopal attack and shortness of breath. Does the patient have impaired relaxation? And does the shortness of breath is because of increase in LA pressure? Okay, look at the echocardiogram first. Look at the attacks here, ladies and gentlemen, and tell me, do you use algorithm 1 or you straight away use algorithm 2? Okay, the patient have bilateral atrial enlargement with severe concentric hypertrophy and ejection fraction is also down. Okay, so you use algorithm 1 or use algorithm 2. So in this situation, you use straight away algorithm 2. Okay, look at the parameters. The LAVI is elevated at 52. The TRV max is elevated at 2.9. The average E over E prime is 18. And the E over A is 1.3. In this patient, we go straight away to algorithm 2. All right. So it is at the middle here, algorithm 2. I think 2 or 3 criteria is positive. So this patient with hypertrophic cardiomyopathy have increased left atrial pressure, which is grade 2 diastolic dysfunction. Again, we can skip algorithm 1 and go straight into algorithm 2. Okay, this patient is in advanced stage of hypertrophic cardiomyopathy. Remember, patient with hypertrophic cardiomyopathy has normally normal longevity, unless about 5% of them go to end stage cardiomyopathy where they develop reduced ejection fraction. Going straight to algorithm 2 with OE over A that is 1.3 and fulfilling all three criteria, the patient have grade 2 diastolic dysfunction. So the LA pressure is elevated. Okay, patient with hypertrophic cardiomyopathy can have systolic entry motion of the mitral valve. I will have a lecture only concentrating on hypertrophic cardiomyopathy. However, those of you who do echocardiogram, just some notes on SAM. It is not only because of Bernoulli principle, it is also because the papillary muscle in patient with hypertrophic cardiomyopathy can be apically displaced. And as it's displaced, the muscle pushes the leaflet nearer towards the septum, therefore more predisposing to SAM. All right. Because you have abnormal septal hypertrophy, the blood flow in the mid of the left ventricle actually twirl in an abnormal way. And this also pushes the leaflet of the anterior mitral valve to the septum, causing SAM. And lastly, when we do pathology, we know that the leaflet of patient with hypertrophic cardiomyopathy is longer than most normal people. On average, AMVL 21 millimeter for normal people and 25 in HCM. For PMVL, about 10 for normal and 14 for patient with hypertrophic cardiomyopathy. Almost more than half now. This is 6 case. An elderly lady with a possible diagnosis of hypereosinophilic syndrome, otherwise known as Loeffler myocarditis. Echocardiogram done shows the presence of both LV and RV apical clot, which is typical of this disease. One tip that this disease always appear on exam. It shows a typical appearance of image. The patient have shortness of breath at rest. Is this because of diastolic dysfunction? All right, let's look at the echocardiogram. Okay, the patient have very poor ejection fraction, cough, both in LV and RV apex. Does the patient have diastolic dysfunction? Look at the ejection fraction, ladies and gentlemen. Okay, do you need to go to algorithm 1 for this patient? No. This patient obviously have abnormal diastolic function. We go straight away to algorithm 2. Now, let's go to our parameters. Do we need to see all the parameters? In this case, do not even do that. You see, your E over A is so high. It is 3.9. So, if you look at your ASE algorithm, you look at algorithm 2, E over A is way higher than 2. So straight away, without looking at anything else, you know that your patient have grade 3 diastolic dysfunction. Okay, patient with hyperinsulinemic syndrome, this patient has very poor ejection fraction, so by definition, already have diastolic dysfunction. Only looking at E over A ratio that is way above 2, we don't need to look at anything else. This patient have restrictive diastolic function, which is grade 3. All right. Typical textbook presentation is left and right ventricle apical clot eosinophilia, and treatment is usually with steroids. Okay. This is our 7th case. We have 60 years old with ischemic dilated cardiomyopathy. Because you have dilated cardiomyopathy, this patient also have mild mitral regurgitation. Patient have shortness of breath. My question to you is, does this patient have diastolic dysfunction? Is this the cause of increase in left atrial pressure? Again, look at the echocardiogram here. All right. Look at the ejection fraction. The ejection fraction is very poor at 15%. Patient have mild functional MR. Does the patient have diastolic dysfunction? So using algorithm 1 or 2. Right, let's look at the echocardiogram. EF is very poor, ladies and gentlemen. EF is 15%. One thing that I wanted to show you here is a nice concept of tethering and tenting of mitral valve. Right? Mitral valve leaflet should coapt at the level of the annulus. If you can see in this patient, the mitral valve leaflet is coapting way at the apex of the left ventricle. So this distance from here to here is what we call tenting height. Okay, this is what we call tenting area. So what happened is, look at my hand here, both the anterior and mitral valve leaflet is actually tented like this. Rather than closing like that, okay, it closed like that. When it closed like that, okay, when it closed like this, it have a lot of coaptation area. When it tethered, it have very little coaptation area. Okay, therefore you have mitral regurgitation. Furthermore, all right, now imagine that this hand here is posterior mitral valve leaflet, and this hand here is anterior mitral valve leaflet. The posterior mitral valve leaflet is always shorter than anterior mitral valve leaflet. So whenever you have functional MR, most of the time the jet is directed posteriorly because the posterior leaflet is shorter. All right. The most important determinant of functional MR is not how big the LV dilate. Okay. It is not how big the annulus. All right. Is how bad is the tenting and tethering. So how bad is the displacement of the papillary muscle. Okay. Now the reason I wanted to show you this is, in a patient with mild valvular disease, so patient with mild MR, it's okay to use a normal diastology parameters. You don't need to worry about that. Only in severe MR do we come into trouble. Okay, other valve there is no issues. So displacement of papillary muscle is the most important aspect of functional MR. So when you look at this patient with obvious diastolic dysfunction, you can see that the E over A in this patient is 2.16, more than 2. So this patient, we do not need to bother with algorithm 1. Straight away, we know the patient had diastolic dysfunction. The E over A is more than 2, and this is restrictive diastolic dysfunction or grade 3 diastolic dysfunction, regardless of the presence of mild MR. Okay. So this is a patient dilated cardiomyopathy with mild MR. This patient have very poor ejection fraction. By definition, he already have diastolic dysfunction. The E over A ratio is more than 2, so that the LA pressure is elevated. The presence of MR will complicate matters. However, this case illustrates that if the MR is mild or less, the normal parameters can still be used to assess diastolic function. For moderate to severe MR or MS, this is the most difficult one, and it's different altogether. The MR due to dilated ventricle pulling the pulmonary muscle upwards. You have tethering and tenting of both leaflet, more so the DBM VL. All right. Let's look at the problem. Okay, so all of these example that I show you is something that is quite straightforward. However, the mitral valve problem is actually also quite straightforward. Okay, the problem with all this entity is that you cannot use your LAVI because your LAVI can be dilated because of your mitral valve disease. You cannot use your E over A. Your E is artificially elevated because of the narrowed orifice. You cannot use your E prime because your E prime is artificially pushed down. So all of these are unreliable in this setting. So what we're going to do next? The problem with significant mitral valve disease, if you have a normal left ventricle, so the left ventricle looks normal, it is almost impossible to tell whether the patient have diastolic dysfunction or not, because all the criteria is unreliable. Okay. So, however, if let's say you have a significant mitral valve dysfunction and your EF is poor, you can say that the patient have diastolic dysfunction because the EF is poor. You can also estimate the LA pressure mainly by using the tricuspid regurgitation of Vmax. However, you cannot tell whether the LA pressure is elevated because of mitral valve disease or because of diseased left ventricle. Okay, so I repeat, in someone with obvious LV dysfunction, okay, I'll give you an example. Okay, let's say you see someone with severe mitral regurgitation and EF is 20%. All right, so your question is, does the patient have diastolic dysfunction? Yes, the answer, because the EF is 20%. Okay. Does the patient have increase in LA pressure? You look at TR, TR is 4, let's say. So the patient does have increase in LA pressure. However, is that increase in LA pressure because of left ventricular disease or that's because of your mitral valve disease? You don't know. So in this situation, severe MR with poor EF and increased LA pressure, what you can say is this patient have diastolic dysfunction because of poor EF. The LA pressure is elevated, but I cannot tell. Is this because of the left atrial pressure or is it because of mitral valve disease? Right? If the patient have no obvious LV dysfunction, it's even worse. Okay, it's very difficult to determine LV dysfunction in the first place. So I cannot determine the LV diastolic function because of significant mitral valve disease. All right. You can determine the LA pressure by TR. Again, the same with someone with obvious LV dysfunction. You cannot tell whether the LA pressure is elevated because of mitral valve disease or because of the disease of left ventricle. There is a proposal, okay? Now, we are talking this about MR, MS, and severe mitral annular calcification. There is a new proposal to treat those with mitral annular calcification because MAC is calcification. You know, patient with severe MAC, if you do your calcium score, the calcium score will be more than 100, okay? So they wanted to treat MAC as de facto myocardial dysfunction. So MAC, just like your EF poor. Therefore, rather than algorithm 2, those with MAC might go straight to algorithm 2, but this is still controversial, okay? So there is no guideline yet about this. I will give you an example. So this is a proposed clinical algorithm for estimated of left ventricular filling pressure in someone with MAC. You straight away look at E over A, just like you do with someone with known diastolic dysfunction. If E over A is more than 1.8, you have high filling pressure. If it's less than 0.8, you have normal filling pressure. If it's between 0.8 to 1.8, okay, you look at IVRT. If it's less than 80, you have high filling pressure. If it's more than 80, you have normal filling pressure. This is for mitral annular calcification. I just wanted to show you, not for you to remember, just so that you to be aware that there is research done in this area. Okay. So this is a mitral annulus E prime velocity versus MAC. So in MAC, the E prime is lower and the E over E prime will be artificially higher, right? What about patient in atrial fibrillation? So we talk about patient in MS and MR, okay? Now we talk about patient in atrial fibrillation, and this is easier. Most of the time, the only problem is because the E over A is fused, we just cannot grade the diastolic dysfunction. But still, we can tell whether the patient have diastolic dysfunction or not, all right? So, LAVI can't be used because AF itself can cause big left atrium. E over A is fused, so that diastolic function grading is not possible. Okay. So, in patient with atrial fibrillation, if they have obvious LV dysfunction, you can use straight away algorithm 2, and you can use average E over E prime, your TRV max, and all your supplementary parameters to decide whether the patient have LA pressure or not. So, for example, someone with AF and ejection fraction, for example, of 20%. So you said this patient with AF have diastolic dysfunction. Okay, you look at the patient other parameters. Let's say the TR is 3.9. Let's say the IVRT is 40 millisecond. You also can say this patient have increase in left atrial pressure. However, the only thing is I cannot grade it because the E over A is fused. In patient with no obvious LV dysfunction, we go to algorithm 1 first. Our only disadvantage is we cannot use LAVI, but we can still use the other parameters to determine whether the patient have diastolic dysfunction or not. Okay. Now, you can use all these parameters that I told you before in atrial fibrillation, deceleration time less than 150 millisecond or 160. Another thing that is special with AF, if you were to do a very slow sweet speed so that you can see a lot of cycle in patient with atrial fibrillation, if you do E over A, if you look at variation, whether it varies with respiration, if it's vary with respiration, it actually predicts a normal filling pressure in patient with atrial fibrillation, as opposed if you do a slow sweep speed and you can see no variation in the E over A. IVRT that is less than 70 milliseconds, this is also the parameter that I've already told you just now. And AFib, they recommend to use septal E over E prime that is more than 11. Left bundle branch block is also a problem because lateral E prime is unreliably high and the septal E prime is unreliably low. However, we can still use other indices. So I just wanted to show you the application of diastology in patient with atrial fibrillation. So this is a patient with history of critical aortic stenosis. The patient also have atrial fibrillation, awaiting operation, however, unable to get out of heart failure. Unfortunately, patient able to survive. Is there diastolic dysfunction? And what is the left atrial pressure? So let's look at the echocardiogram here. EF is 20%. All right. The AVA from continuity equation is only 0.3 centimeters squared, so very small. The mean gradient is 110, it's extremely high. Okay. Now look at the echocardiogram here. All right. Tell me whether you want to use algorithm 1 or straight away use algorithm 2. All right. Remember, this patient does not have a significant mitral valve disease. Okay. However, the ejection fraction is down and significant aortic valve disease. Remember, significant aortic valve disease still allow you to use a normal parameters. So this patient have atrial fibrillation, ejection fraction is down, right? So look at the parameters. TRV max is 3.9, that is abnormal. Average E over E prime is way high at 48, all right? And also, I told you we can use all the other supportive parameters to support increase in LA pressure, okay? The quality of tissue Doppler in this situation, it is not so good, all right? So this is a tip for your sample volume, for your pulse Doppler and tissue Doppler. Make sure you do it correctly. Gain and scale should be reduced for better tracing. However, our patient ejection fraction is only 20%. Straight away go to algorithm 2, okay? You cannot use the left atrial volume index, correct? Because AF itself can cause increase in LAVI. However, you can use the E over E prime and TR velocity. So our patient E over E prime is way high. The TR velocity is way high, okay? So we know that our patient have increase in left atrial pressure. So what is our conclusion for this patient? So this patient have critical aortic stenosis with poor ejection fraction and atrial fibrillation. The patient have diastolic dysfunction as EF is poor and the LA pressure is also elevated. However, I cannot grade because the EA is fused. The patient is in atrial fibrillation. So that is how you approach patient with atrial fibrillation. Okay. Patient have elevated LA pressure, but we cannot grade the diastolic dysfunction. So patient with AF and critical aortic stenosis, in this patient, we can say he have diastolic dysfunction as the ejection fraction is poor. The second question is the LA pressure, and from the average E over E prime and TRV max, we can say that the LA pressure is elevated. So even though we cannot grade the diastolic function, we can still say patient have diastolic dysfunction, and this cause increase in LA pressure. This also shows that the diastology indices can be used in patient with aortic valve problem as opposed to mitral valve. Right? So now we go at our penultimate case, our ninth case. Thank you so much, guys, to be very patient. We have a patient with chronic severe MR secondary to flail posterior mitral valve leaflet with anteriorly directed MR jet. Now we have severe MR. Now we are in trouble. Okay. The patient also have atrial fibrillation. Not only have severe MR, also have AF. Is there diastolic dysfunction and is the LA pressure elevated? Now, let's look at our echocardiogram here, all right? So this is our left ventricle and our left atrium. There is flail posterior mitral valve leaflet here. Let's look at our parameters, right? This patient have severe MR. Patient also have EF, AF. The EF is 46%. So the EF is down for this patient, okay? Now, does the patient have diastolic dysfunction or not? All right. Now, if you were to take 50% as normal ejection fraction, okay, you know that EF that is 46% is not normal. So we know that this patient have diastolic dysfunction. Okay. If this patient have EF that is 50 something, we cannot tell whether the patient have diastolic dysfunction or not. Okay, because our parameters cannot be used. Now, this patient with severe MR, let's look at other parameters. Okay, so this patient straight away we use algorithm 2. Okay, patient with severe MR with poor ejection fraction, so patient have diastolic dysfunction. However, how are we going to determine the LA pressure? Because all of our criteria here, E over E prime, TR velocity and LAVI cannot be used. So we need to see a supplementary criteria for this patient, right? So this patient have reduced ejection fraction, so does have diastolic dysfunction. However, all the other indices in algorithm 2 is unreliable, all right? But we can still use the TRV max. So one of the index is useful. You can use IVRT. You can use the pulmonary vein flow to estimate LA pressure. But we cannot attribute it to solely to LV dysfunction. For example, let's say our patient with chronic severe MR, EF that is down, have TRV max of 3.4, have diastolic dysfunction because EF is down, have increase in LA pressure because TR is 3.4. However, you cannot say whether the LA pressure is something to do with the diastolic dysfunction of the left ventricle or just because of the severe mitral valve regurgitation itself. So that is how we approach. So this patient have diastolic dysfunction as the EF is down. The LA pressure is elevated because the RV max is elevated. However, this cannot be attributed to diastolic dysfunction of the left ventricle with certainty. So that is how we approach a mitral valve problem in patient. Our last case, ladies and gentlemen, is 31 years old lady with chronic rheumatic heart disease with combination of MS and MR. Is there diastolic dysfunction? Is the LA pressure elevated? Right? Like at the echocardiogram of this patient, ejection fraction is 40%. So we know the patient have diastolic dysfunction straight away. So we go to algorithm 2. However, unfortunately, patient have severe mitral stenosis with planimetry of 0.9 centimeters square. Therefore, the E prime will be artificially low and the E capital will be artificially high. You cannot use it. You cannot use your LAVI. Okay. There is also sign of right-sided overload, meaning that there is left atrial pressure elevated, causing right-sided pressure overload. So your left atrial pressure is elevated. However, again in this situation, because of severe mitral stenosis, even though you know the patient have diastolic dysfunction, because the EF is 40%, and you know the LA pressure is elevated, you cannot tell whether this is because of the mitral valve or because of the problem with the left ventricle. Okay, so the patient have systolic pulmonary artery pressure of 62 millimeter mercury. All right, EF is down, so straight away go to algorithm 2. We cannot use average E over E prime. We cannot use LA volume index. We can only use TRV max. So in this patient with rheumatic MS and MR, as the ejection fraction is down, the patient does have diastolic dysfunction. In this patient, the PA pressure is elevated, suggesting high LA pressure. However, any surrogate for LA pressure, such as IVRT, deceleration time, and TRV max, cannot be attributed to diastolic dysfunction. Okay? So in this situation, we can say that the LA pressure is elevated, but we don't know where does that originate from. Now, ladies and gentlemen, That is the end of our really long lecture, the end of 10 cases of diastolic dysfunction. So it is 10 cases for you to remember, 10 parameters for you to remember. I hope that the lecture is clear and diastolic dysfunction is no longer a mystery for you all. So what is the take-home message? Always look for obvious left ventricular abnormalities, guys. Doesn't matter what's the etiology, diastolic dysfunction is present. Remember that 3 criteria. In patients with normal left ventricle and only fulfill one or none of algorithm 1, patients have normal diastolic function. Stop there. If you look at a normal left ventricle, always start with algorithm 1, unless otherwise you will let astray. In patients with normal left ventricle and they fulfill 3 or 4, diastolic dysfunction is present. Proceed to algorithm 2. In patients with normal left ventricle but only fulfill 2 of the first algorithm, try to use that additional index that was mentioned previously. Most of the patients, we can determine their diastolic function. In patients with mitral valve disease, the determination of diastolic dysfunction in patients with normal LV function is almost impossible. Even if the LV is abnormal and diastolic dysfunction is present, unable to attribute increase in LA pressure to diastolic dysfunction in mitral valve disease. In patients with atrial fibrillation, usually diastolic function and LA pressure can be determined, but no grading as the E over A is fused. All right. So, ladies and gentlemen, boys and girls, this is my last slides of the talk today. All right. And I just wanted to show you the 10 parameters. Okay. And I hope you can repeat it without me showing you first. Okay. Number 1, septal E prime that is less than 7 is abnormal. Lateral E prime that is less than 10 is abnormal. Average E over E prime that is more than 14 is abnormal. TR max that is more than 2.8 is abnormal. LAVI that is more than 34 is abnormal. IVRT less than 70 is abnormal. Deceleration time less than 150 milliseconds is abnormal. Pulmonary vein atrial reversal duration minus mitral valve airway duration more than 30 milliseconds is abnormal. The presence of LVF is abnormal. And lastly, positive Valsalva maneuver did not increase in left atrial pressure. Now, thank you very much because all of you joined me for this lecture. I'm happy to give about 5 to 10 minutes for question and answer session. Please type in the chat group what you think about the talk. When do you want the next lecture to be? Thank you very much, guys. Right. So, any question? All right. Let me